Today on ASNC Health Policy 101, you'll learn how ambulatory payment classifications or reclassifications can have drastic effects on payments for the services you deliver. I'm Randy Thompson, president of ASNC. I've worked on ASNC advocacy initiatives for many years and have seen firsthand why ASNC's exclusive focus on nuclear cardiology is important for our field, our practices, and our patients. Ambulatory payment classifications are an excellent example of how an issue that may seem like a technical matter that you can leave to your practice administrator or coder, but that's not the case. It's crucial that we have ASNC monitoring what's happening at Medicare and protecting the payment codes our practices need in order to provide optimal patient care. Let's start at the beginning with the definition of an APC. APC stands for Ambulatory Payment Classification. APCs are used in the hospital outpatient department. So if you work at a hospital outpatient clinic, this is how your reimbursement works. Think of an APC as sort of like a DRG, except for the outpatient department. It's a bucket containing a set of clinically similar medical services that require similar resources to provide. All of the services in a particular APC share similar clinical intensity, resource utilization, and cost to perform. And importantly, every service in an APC bucket receives the same reimbursement rate from Medicare when they're delivered within a hospital outpatient department. CMS calculates a payment rate for each APC by assessing the geometric weight or average of the hospital service cost in the APC relative to the hospital cost of clinic visits. APCs are scaled to payment rates for clinic visits because clinic visits are among the most frequently furnished services in the hospital outpatient setting. It is very important for us as nuclear cardiology professionals to know which APCs contain the services we provide. You should be aware of the buckets where your services are located and which other services are viewed as clinically similar to them. Nuclear cardiology services are grouped in the nuclear medicine APCs. The family of nuclear medicine APCs contain four major APCs, specifically 5591, 5592, 5593, and 5594. So all the services in APC 5593, for example, get paid at the same rate. The services in the nuclear medicine APC are packaged. This means the cost of the radiopharmaceutical and all ancillary supplies integral to providing the service are reimbursed in a single payment rate. This is different from services provided in physicians' offices or the physician fee schedule, where items like the cost of the radiopharmaceutical are paid separately. The main reason that APCs are important is because there can be drastic consequences for payment rates if a reimbursement code is reclassified or if a new code is placed in an existing APC. The best way to demonstrate this impact is with an example. The payment rates shown here are for illustrative purposes only. You can find the actual payment rates associated with each APC on asnc.org. In this illustration, you see payment rates for several nuclear medicine APCs. Remember, all the services in an APC receive the same payment rate, and the rate is calculated averaging the cost of all the services in that bucket. So let's say a certain code starts out in bucket 5591, which has a payment rate of $350. Now imagine CMS moves that code to APC 5594. The service would then be averaged in with the other services in 5594, which were being reimbursed at $1,350. The service would be a massive pay cut for the services in APC 5994. Now consider another scenario. Stakeholders who are interested in new technology may try to persuade CMS that the new service is clinically similar to a nuclear medicine procedure. They may argue to CMS that the new service should be placed in a nuclear medicine APC. Let's say, for example, this new technology had a current payment rate of $950, and advocates for the new service lobbied for it to be placed in nuclear medicine APC or bucket 5594. You can imagine what would happen. The proposed technology's lower rate could pull down the payment rate for all the services in APC 5594. And when an APC or its payment rate is changed for Medicare, private payers often follow suit, compounding the effects on reimbursement. So really, hospitals take the APC rate, and that's the starting point for their negotiation with insurance carriers for what rate they're going to charge. So if the APC goes up or down, if it's generously reimbursed or stingily reimbursed relative to the cost, that doesn't matter. They generally just go with a multiplier effect on the APC cost. In addition to the math involved when services are reclassified, there's another important point to consider with APCs. It is crucial that the clinical homogeneity of the nuclear medicine APC be maintained. Currently, all the services in the nuclear medicine APC use radiopharmaceuticals, which require special equipment and resources for safe use. For example, as you know, a hot lab must contain dose calibrators, various lead shielding equipment, emergency spill kits, specialized lead line waste receptacles, and many other items tailored to the safe and effective use of radioactive materials. Those requirements carry significant costs that should be fairly accounted for in reimbursement. If the nuclear medicine APC were diluted with services that do not require these resources, and thus pull down the APC's payment rate, then the cost of the hot lab requirements might not be fully covered. And that would have drastic consequences for the financial health of our practices. CMS has the authority to decide which services go into the APCs. However, CMS is counseled on the APCs by the Advisory Panel on Hospital Outpatient Payment. The panel is made of 15 members who are representatives of healthcare providers. The panel advises CMS on whether services in the APC are clinically similar in the resources they require. The panel may also weigh in on proposed reconfigurations of APCs and policies regarding how items and services in specific APCs are packaged. The most helpful thing you can do as individual practitioners is to watch for ASNC updates. Most of ASNC's calls for actions related to APCs come in midsummer. That's when CMS typically issues the proposed rule for the Hospital Outpatient Prospective Payment System, or HOPS. You've probably noticed that ASNC issues an alert soon after the proposed rule is posted. Now, analysts comb through each proposed rule for changes that could affect the nuclear medicine APC. If there are proposed changes that will impact our payment rates, ASNC submits comments to CMS. That's when we may ask you to submit your own feedback to CMS to help amplify ASNC's message. I hope this information provided today illustrates how APCs affect payment for hospital outpatient services and why ASNC monitors APCs so closely. Stay tuned for the next episode of Health Policy 101.